Welcome, welcome, welcome in, everyone. Welcome to Care Concierge with Care Patrol, where education is the heart of everything we do. Welcome to our CEU today, Ageism in Healthcare, which is an ethics unit. We welcome you to Care Patrol and Care Concierge. If you're new with us, thank you for being here. Care Patrol is an aging care advocate form agency. We assist people with finding what are their care options, how are those paid, and like a real estate agent, we tour communities if that is the appropriate placement with our clients. We have been in business since 2011, have helped probably over 4,000 families, and would love to help your patients, clients, friends, and family. We work much like a realtor, and we're paid much like a realtor in that we're free to the families and patients that we work with. We're paid by providers within our network, and we're so happy to have you here today. If you're new to us and you're new to Zoom, we do really encourage discussion. We love to hear your thoughts added to mine, and certainly if I misspeak, I'd like for you to feel comfortable in correcting me. Everyone who is here in order to receive credit must provide an evaluation. That evaluation is password protected, and the reason that we do this is to show that to the Alabama Board of Social Work, which is one of the bodies that accredits us, that this is a live hour or a classroom hour, and I know those are beneficial to you as social workers. Nurses were also approved for 1.0 contact hour by the Alabama Board of Nursing. Our evaluation, which is password protected, we give the password out at the end, but I know that many of you are participating by phone or not looking at a screen, otherwise unable to see our link. So let me read it to you now. And again, it's password protected. We give the password at the end. The evaluation link is https colon www.surveymonkey.com /lowercase r / all uppercase letters with numbers 3 2 Z as in zoo, C as in cat, 5 6 Q. That's our evaluation link for today. It's password protected. We do encourage discussion. If you're new to Zoom, please move your cursor to the top of your screen or the bottom. On that, a black bar will appear, and on that bar, the words chat. Click on that and join in the discussion. Let's get started. Our three objectives for today are these. Define ageism and its effects and how this may affect us ethically. Our second objective for today is to list at least 5 misconceptions we may have about aging and how these might affect how we treat people ethically. And third, our objective is to provide ethical examples of how we can combat ageism. So we welcome you in today. Let's get started by asking this question of you. What is ageism and how does it affect us? What is ageism and how does it affect us? Please join in the chat room. I've posted again for you here the survey link so it's easy to get to. What is ageism and how does it affect us? Good morning, Ms. Cronin. Thank you for joining the discussion and speaking up. Good afternoon, Ms. Shaw and everyone else. What is ageism and how does it affect us? Well, ageism does not operate any differently than the other isms that we encounter: sexism, racism, classism, and other forms of injustice. Ageism works in tandem with these and perhaps causes a double jeopardy. Women experience this, both sexism and ageism. as we look at standards of physical appearance in our society and how these are often aligned with youthfulness being equal to beauty. Men are often exempt from these standards. My gray hair and wrinkles may give people the association that I'm somehow experienced or intelligent or wise, whereas these same wrinkles and gray hair may stigmatize women due to the beauty standards that persist in our society. Society, as we know, values individuals who are attractive and productive and worthy in relation to their age. And we see that individuals can suffer negative health impacts when these negative value judgments are internalized. And this cycle is reinforced throughout the interactions throughout our lives and the policies that guide our institutions that are based on ageist assumptions. Middle-aged adults, in fact, and you may be there at this point in life, where we're expected to buy into the consumer culture, wherein youthfulness is beauty and youthful and anti-aging products are all the rage. Just as a little bit of background, retirement is a social construct. It was invented during the Industrial Revolution, and at that time, the government put benefits into place to help transition workers out of the work life. In the 1950s and beyond, and even into today, builders and marketers built retirement communities, which further secured retirement as a life stage. But not all people can or want to retire or can afford to retire. We've seen that medicine has made groundbreaking advances in the detection and treatment and prevention of age-related diseases, but these same efforts have caused our focus on aging itself to view aging as a disease. Aging is not a disease. Thank you, Ms. Hunter and Ms. Worley, for your comments in the chat room. The media, as we see today, uses guilt, fear, and shame, and has done so since it began booming in the 1950s. And appearance-based shaming exists for both men and women, though again, for women, it's a much greater and more double standard than for men. Visual ageism begins even in our early childhood with fairy tales, where we see the concept of the wicked old witch and the youthful, beautiful young princess, where old is bad and younger is good. We tend to see even in fairy tales that older adults might be depicted as sad or lonely or frail or sick. Think no further than Geppetto, the father of Pinocchio, to find that example. But there is no typical 65-year-old or 85-year-old. And in fact, we see that people become more individualistic as they age, not more similar. And while we see older adults depicted as frail, incompetent, gullible, malicious, or just absent from popular media, we see compliments, so-called, such as "you look good for your age," or we might even say to someone, you know, "I'm having a senior moment." We're internalizing ageist beliefs. And then there's the infamous birthday cards that we've all seen while waiting on a prescription at the drugstore, which poke fun at age and aging, particularly as you get more advanced in age. Nelson said that ageism itself is a prejudice against our feared future self. A prejudice against our feared future self. Thank you, Ms. Clark, for your comment. And it's good, Ms. Clark, that you noted that we also have derogatory comments about people who are younger as well. We all internalize these negative stereotypes about aging. And if you are in the healthcare setting, internalizing and making assumptions that older people are challenging somehow to care for, that older folks are frail or unproductive, that they are dependent on others, or that they may be cognitively impaired, these biases can lead us to unfair treatment in the healthcare setting. And difficult decisions are made in healthcare, and it's not uncommon in healthcare for healthcare services to be rationed. Providers may favor younger people due to the assumption that illness and death is somehow more common and more acceptable among older adults. An example we saw during COVID-19, when voices in the media expressed that COVID-19 was not as much of a threat because it primarily affected only older people. And we saw that medical interventions should then target younger generations and not the aging. We even saw that there was a call for a targeted lockdown of older adults, which somehow promised to reopen the economy. Here in the state of Alabama, we saw that Alabama rationed medical care, including ventilators, based on age and disability related cutoffs. So we can see how pervasive this is in healthcare and how damaging. Ageism predictors exert their influence on our health through three pathways: the psychological, the behavioral, and the physiological. In the psychological pathway, we see with loads of research, decades now of research, that negative age stereotypes can exacerbate stress. When older participants are randomly assigned to age stereotype conditions in the clinic or in the lab, on the behavioral level, we may see that research finds that negative self-perceptions of aging predict worse health behaviors over time, including non-compliance with prescriptive medicines. On the physiological level, we find that negative age stereotypes predict detrimental brain changes decades later, including the accumulation of plaques and tangles and reduction in the size of hippocampus, which are the markers of dementia. Here's a comment I'd like to read from Ms. Clark. I recently had a 95-year-old customer tell me that providers do not want her to bathe without anyone in the house. However, a home health aide only comes 3 times a week. The customer lives alone and does not feel unsafe bathing independently. And that is a perfect example of what we are talking about here. One of the primary theories on ageism is called stereotype embodiment theory. And this was developed by Dr. Becca Levy in 2009. And she stated that age stereotypes are internalized from a young age and accumulate then across the lifespan, and that this has significant impacts on well-being. Dr. Levy and others have performed numerous studies that demonstrate the adverse impacts of internalized ageism or stereotype embodiment theory. One is she found in 2002 that positive self-perceptions of aging led to increased longevity of about 7.5 years. That's a long time. Resisting negative age stereotypes has been also found to be associated with less post-traumatic stress disorder and even suicidality among the aging. Younger people, Dr. Levy found in 2009, who embraced the more negative age stereotypes are found more likely to experience a cardiovascular event at age 38 years and older. More likely to experience a cardiovascular event. Older adults, however, with positive age beliefs were found to be nearly 50% less likely to develop dementia, even those individuals who would be considered to be at higher risk due to carrying the E4 variant of the APOE gene. Dr. Levy found this in 2018. So stereotype embodiment theory is physiological then. It's the way that we internalize age stereotypes, which leads to increased stress in the body. In healthcare settings, ageism displays itself in everyday conversations with the folks that you meet in clinic, within the physical space with which you are involved in clinic, and with the policy choices made by the agency or a medical provider with whom you're associated. Ageism is a social justice issue and it is a civil rights issue. And it describing older adults without a focus on decline is what we're looking for. 2 decades of evidence-based research now show ageism's physical, psychological, social, and economic consequences. The subtle messaging that we receive about aging both in childhood and beyond, is that younger is good and older is bad. But aging is not something that just happens to older adults. Ageism happens to all of us. Every moment of our lives, we are aging from birth on through to death. I'll ask you, and I'd love to hear your answers. What is the cost of ageism in healthcare? What is the cost of ageism in healthcare? What is the cost of ageism in healthcare? And I'll look for your comments. We frankly devalue people who care for older adults. You can look no further than to see that geriatricians are significantly paid less than other medical specialists, which shows again that we devalue the work that both doctors and care workers with the aging provide. Most healthcare aides, those who are providing intimate and personal care that helps provide dignity and humanity and independence to those that they serve, these care workers are often asked to work 2 jobs just to have a livable income, which causes further undue stress on their lives as they are aging and juggling childcare and transportation and other family demands. And we saw that even 10 months on into the pandemic, that still nursing homes and assisted living communities were still struggling to get the proper personal protective equipment. And here are some of your comments. Assumptions based on generalizations, diminishing services. You're right, Ms. Hurd. I don't know an exact amount, says Ms. Fuqua, but I know that as the patient, it seems to get more expensive. That's a good point. Ms. Clardy says, because this person with a certain disorder acts a certain way, then everyone with that disorder will be that way. I'm not sure I understand that, Ms. Clardy. Maybe you could elaborate. And sometimes death because doctors and care workers don't give their all in care. Over 63 billion per year, says Ms. Hunter. You're correct. And less work ethic these days, says Ms. Boozer. Well, the highest cost among the 3 predictors of ageism is cardiovascular disease. And as we just stated moments ago, exposure to negative age stereotypes leads to heightened cardiovascular stress. And it predicts the risk of experiencing cardiovascular events, according to research by Levy and others, along with the cost then of treating those cardiovascular, the hard cost, the dollar cost of treating those cardiovascular conditions. There are several, in fact, predictor outcome associations found in the Association of Age Discrimination and Negative Self-Perceptions of Aging with persons contracting diabetes and musculoskeletal disorders. Ms. Langley says, I've heard of some surgeons refuse to perform surgeries on an individual that's over a certain age. That's true. One caveat of that might be that those that have dementia or are prone to dementia may not bode well with anesthesia. Do you know that 1 in 17 adults who are age 50 and over report experiencing frequent age discrimination in healthcare, which may contribute to new or worsened disabilities in those patients and can literally, as someone pointed out earlier, have life or death implications. Older patients who experience it have a higher probability of death than younger patients. Ageism takes the form of prejudiced attitudes and discriminatory behaviors towards older adults. Negative ageist beliefs inadvertently impact older adults' health with poorer health outcomes, increased cardiovascular stress, as we've discussed, psychological distress, such as PTSD and suicidality, poorer performance on cognitive tests, increasing the risk for depression and anxiety, and increased mortality. This is from a series of studies that Dr. Levy was included in. Combating ageist views is therefore a challenge because these views are often so perpetuated unconsciously within each of us as practitioners through the stereotypes that we imbibe throughout our lives. One way then, to discredit ageism and reduce it is to discredit the common stereotypes. Ms. Cronin says, I think many older adults either have the idea that I'm so old I must have a lot of prescriptions, or they just do not even go to the physician for appointments. Either way, the amount of cost for prescriptions is extremely high. And then if there is no preventative meds or care, the cost may be higher. Well said. My 84-year-old mother-in-law says that getting old is not for the weak. And I've said that myself. And that's an ageist stereotype that she and I have both internalized. Ms. Clark says, I have personally witnessed the negative impact of anesthesia on an older adult near and dear to my heart. It was hard to watch and irreversible. However, I understand that every case is unique. What misconceptions about aging do you have that may lead you to unethical behaviors and practices? And this is a difficult question. It requires some self-examination. What misconceptions about aging might you have that may lead to unethical behaviors and practices? Please share in the chat room. And I thank you all for being so engaged today thus far and sharing in the chat room. What misconceptions about aging might you have that may lead to unethical behaviors and practices? Let's review those now. Well, one misconception that many of us hold is that good genes somehow equals healthy older adults. But genetic makeup is only one factor. The social, behavioral, lifestyle, and environmental factors also play a role in shaping our longevity. And healthy aging then starts at birth with our genetic inheritance, but only about 25% of the diversity in longevity is explained by genetic factors. The other 75% is a cumulative impact of our interactions with our physical and social environments across the life course. 75% is the cumulative impact of our interactions with our environment, but they also have to do with the quality of our schooling, the safety of our workplaces, the cleanliness of our water, food, and air, and the nature of our social interactions and relationships. And here you can see the other isms come into play, such as classism, racism, sexism. All of these things have to do with the quality of schooling, the safety of workplace, the cleanliness of water. Ms. Hurd says that all my senior, in quotes, clients are getting their needs met in therapy. Some do not know how to ask for what they help or need. And Ms. Clark says, I remember learning in graduate school that people will develop some form of dementia if they live long enough. I do believe there's a difference between senility, normal memory loss, and dementia, and that is actually true. And it's 1 in 3. And once you are in your early to mid 90s, you have a 1 in 3 chance of developing dementia. That's from a former CEU of ours. And those of you who are new to our Care Concierge series, do know that you can find other topics at YouTube. If you go to Sean Barnes Carepatrol in the search bar in the YouTube app itself, we'll pull up a page with about 110 different CEUs, everything from dementia to self-care, ethics units, and other units, and all of those are available to you there, and I hope you'll make use of them. Michelle Worley says accepting certain things as, quote, part of aging might actually be treatable. That's so true. And Ms. Ward says, I realize it is incorrect and unfair to assume that all older adults are frail and dependent. This stereotype is not true and can be harmful to seniors who are capable and independent. That is wonderful. Well said, Ms. Ward, and congratulations to you for making that comment. Another misconception that we may have about aging that colors our interactions and thus causes us to act in an unethical way is that somehow the only predictor of good health and well-being as an older adult is the absence of disease. But we know, those of us who see them, that older adults are likely to experience multiple health conditions at the same time. but still are able to continue doing things important to them. A combination of someone's physical and mental capacities then is known as intrinsic capacity. And intrinsic capacity is a predictor, in addition to the presence or absence of disease, of how old someone is and how healthy someone is. This intrinsic capacity framework was proposed by the World Health Organization, and it includes cognition, mobility, psychology, vitality, and sensory functions. Ms. Hunter says, my 101-year-old aunt wanted to explain to the doctors her medications and feelings. Instead, they would look to the person next to her to explain. She did not like that because she was well capable of explaining and speaking for herself. And I wonder if any of you have had this experience, even perhaps done this when you were dealing with an older adult. Ms. Hurd says, so happy to find this training. My 93-year-old mom lives with us and is exhibiting sundowner syndrome right around 4:30 p.m. nightly. I'm sorry to hear that, Ms. Hurd, and I'll be thinking about you and your family. Another misconception that we may hold that would lead us to act in an unethical manner, such as looking to the person with the older adult while in clinic, would be that all older adults are the same. There is no typical way to define an older personality. In fact, the older adult population is characterized by great diversity. Experts in aging, geriatricians who are underpaid, will often say to you, if you've seen one 85-year-old, you've seen one 85-year-old. And we know that the population of 85-year-olds is growing. In fact, we know that the baby boom generation, which spans nearly 20 years, started turning 65 in 2009 and will continue turning 65 until 2030. 10,000 people a day turn 65. So that in just a short span now, those who turned in 2009 are now approaching or in their 80s. So we're seeing that big boom of folks grow into an older population. Miss McKenzie says, my dad and his wife are 91. They live independently, and he gets offended when I treat him like he is old, such as offering to fix his plate for him. That's very self-aware, Miss McKenzie. The silver tsunami is what I have it referenced as, and that's correct, Ms. Hurd. The baby boom generation, as you might expect, these are the people who were at Woodstock. This represents a heterogeneous group of people whose experiences, values, and life stages vary not only from preceding generations, and I would say from anteceding generations, such as mine, but also from one another within the boom generation. Diversity then in aging population will only continue to grow as the aging population itself continues to grow. We'll see between 2010 and 2030, the population of people of minoritized backgrounds over 65 will increase by 160%, compared with 59% for the white population. I was next in line at the grocery store, says Ms. Cooper. I observed a customer in front of me casually speaking to an older cashier. The customer spoke in a loud tone. The cashier had to tell the customer she was not hard of hearing. Again, these are ageist stereotypes that individual had internalized and was using, and really I would say was unjustly using, unethically using with the older person. Another misconception that we may have about aging is that most older adults will end up in a nursing home. But it's estimated that 70% of people over 65 years of age will at some point enter a nursing home. That stay will likely be short-term rehab for physical therapy from recovering from surgery or an accident. But only about 5% of older adults will live in a nursing home for the remaining years of their lives. Ms. Burke says, I often see families trying to send their loved ones to nursing homes, even though they are able to care for themselves at home, as we just discussed. Another misconception that we may have that will cause us to internalize negative age stereotypes and act unethically is that depression is common among older adults. And while ageist stereotypes can lead to increasing rates of depression, depression itself is not a normal part of aging. In fact, research shows that depression in older adults is not more common than compared with younger counterparts. In fact, the rate of depression is significantly lower in older adults compared to younger and middle-aged adults, and depression is less likely, studies have shown, to occur as individuals age. In fact, the 12-month prevalence rates for major depression in older adults ranges from under 1% to right at 10%, compared with estimates over 10% in younger adults and up to almost 10% in middle-aged adults. Now, remember, that's a range, so we're saying that older adults are less likely, not more likely, to be depressed than their middle-aged counterparts. However, we do see depression higher in older adults who are living in long-term care, ranging from 5% to about 25%. But again, the median is still only 10%, the same as middle-aged adults. Another misconception we may have will be that aging adults, and someone said it earlier, most older adults will experience some form of dementia, such as Alzheimer's disease, but dementia is not a normal part of aging. In fact, studies show that our verbal and math abilities and abstract reasoning can actually increase with age, and the risk of dementia is not inevitable. Only about 5% of individuals between 71 and 79 are affected by dementia, and many people live into their 90s and beyond, 2 out of 3 in their 90s, without significant declines in thinking and behavior. Mild forgetfulness is common at any age. You may forget your keys. You may have forgotten if you've taken your medications this morning. That does not mean you have dementia. It is not a predictor that you will have dementia. And we see that physical exercise and social interaction can help keep the brain sharp and avoid dementia. If you worry whether someone may have dementia that you're seeing in clinic or in your agency or in your work or in your personal life, the National Institute of Aging provides some guidance to us. Dementia would be asking the same questions repeatedly, getting lost in a place the person knows well, having trouble following recipes or directions, becoming confused about time, people, and or places, and not taking care of oneself, such as not bathing or eating properly or taking the proper precautions in life. Ms. Clark says, I forget why I entered the room sometimes and I haven't hit 50 yet. Me too, and I'm 57, but I don't worry about dementia. In fact, I work to not have dementia. One thing is, another misconception is that an individual's chronological age is the best means to determine when someone is old. But chronological age itself is a poor indicator of old age. And we have become accustomed through social and cultural norms to believe that chronological age somehow is a predictor of our abilities, such as the way that we place an age on voting or driving, drinking, or retirement, even, as we discussed earlier. Not all of us look to retire at 65. But in the US, people are generally considered old because the retirement age is 65. But we should remember that this age and chronological age itself is an arbitrary number. We would be better to look at functional age, how an individual looks and what they can do as a predictor of how, quote, old someone is. And a person then would become old when they were no longer able to perform the major roles of adulthood or might need assistance with activities of daily living. Functional age itself can be inherently ageist as it focuses on characteristics of decline, but ignores attributes that can actually improve, such as wisdom, and happiness. Ms. Hurd says, my dad worked up until the day he died at 91. And I would say, Ms. Hurd, that's my hope for myself. Subjective age, how old or young a person feels and their perceptions of when other people become old, is also inherently ageist, but you're only as old as you feel, you might have heard. The key factors in subjective age identity are health, activity level, cognitive abilities, gender, and social class. So again, the isms are mixing up here. Perception of when other people become old shifts by the age group. We see that persons who are 18 to 29 tend to think old age starts at 60, while people who are age 65 tend to think of other people as old starting at age 74. So we can see that just as we vary individually one from another, so do our aspects or our beliefs about aging. How we think about aging and age and its meaning varies from one person to the next. Yet another misconception that may cause us to mistreat unethically someone that we're in contact with would be the belief that somehow older adults contribute less or little to society. Older adults, in fact, contribute to communities through volunteering, providing companionship one to the other, and for the younger generation through their philanthropy and through work, through assisting with small businesses. Some older adults we've seen even start second or third careers, whereas in the past, retirement was considered a single event. You retire and then you die. Today, it's not recognized as a permanent departure from the workplace. Today, many older and aging adults hold bridge jobs. They may phase out in retirement. They may go part time or participate even in the gig economy. I wonder if any of you have ever had an Uber driver, as I have, who appeared to be in his second career over age 65. We know, and someone said earlier in the chat room, that older workers have a strong work ethic. And they bring with this work ethic years of professional expertise, hard and soft skills that they have created for themselves and are willing to share. Older adults can be great mentors and role models for younger generations. So those are some of the misconceptions that we may have about aging that may cause us to act unethically. In what ways, then, I would ask you, might you unintentionally be subject yourself to unethical ageist views or behavior? In what ways might you unintentionally be subject to unethical ageist views yourself or ageist behavior? Ms. Cronin says, I have volunteers that are in their 70s. They are very capable. Ms. Hurd said, yes, I chose to go to grad school in my mid 40s and pursue my licensed care social work, setting up for my twilight career. Congratulations, Ms. Hurd. Well, one of the ways that we might be unintentionally prescribing to unethical ageist views is through the ways that we communicate. Someone pointed this out in the chat room where someone was yelling at an older adult as if that somehow helped with their comprehension. The other thing that I would say that you may be subject to is elder speak, which is essentially baby talk, where we communicate with older adults, particularly those that may have dementia, based on these negative age stereotypes that persist, that we consume and have consumed from birth. Elder speak portrays older adults as incompetent. It's patronizing and it's manipulative, and it may include things like speaking more loudly or speaking more slowly. It may include using a higher pitch or tone to our voice, or it may include the use of inappropriate terms such as honey or sweetie when speaking with older people. Have you ever been subject to this? Ms. Clark says, yes, I once had an older Lyft driver on the trip to the airport. He was unable to help with the luggage because of his back, but we had a great conversation and he shared a book recommendation with me. That's wonderful. Ms. Ward said, I recently had a conversation with a cashier at Publix. To my surprise, he revealed that his first job was an engineer. That's wonderful. He retired as an engineer and his bridge job is working at Publix. I love hearing that. So elder speak was identified in 84% of the interactions in one recent study between nursing home staff and their patients. 84%, that's quite a lot. Elder speak itself is a form of implicit bias that contributes to paternalism and reduces person-directed care in healthcare. We saw someone in the chat list an example of her 101-year-old for whom the doctor looked at the person with her instead of looking at her to ask about her condition. So elder speak disempowers and limits older patients' autonomy, as was done to this person in the chat. Counteracting this elder speak requires us, you, as healthcare practitioners, to develop, as we hope you're doing today, a concept of the self-awareness of your implicit bias about aging and ageist stereotypes and embodied stereotypical theory, and that you may learn to practice new communication patterns when interacting with older adults. Ms. Clark says, I've also connected well with older people since childhood. I suspect it's because I'm an only child and spent a lot of time with adults. I feel the same way, Ms. Clark. I'm an only child, and my mother was a single parent, so I grew up with aging folks. I spent a lot of time with my grandparents. That actually led me to do what I do, to work with Carepatrol, because I have a real affinity for aging adults and always have. So here's some features of elder speak and some alternative strategies, as we said we would provide you. Sometimes we use diminutives like honey, sweetie, dearie. These imply that we are somehow the parent to their child. An alternative strategy would be to refer to someone by their full name or by their preferred name, Mrs. Robinson or Geraldine, for example. The inappropriate use of plural pronouns is a form of elder speak when we use the collective, such as we, when referring to someone who is older and yet independent. For example, are we ready for our medicine? Alternatively, are you ready for your medicine? And then we may end up using in elder speak tag questions, where we might say, you would rather wear the blue socks, wouldn't you? In other words, we're taking the decision making out of the hands of the older person and doing it for them. The alternative would be to say correctly what we mean. Would you like to wear the blue socks? Now, these and other things, such as shortening our sentences or slowing our speech or using a more simple vocabulary, these do not improve the comprehension of speech for most older adults and are generally perceived as patronizing and demeaning. So how can we combat ageism in healthcare? This is the goal of this hour today. How can we combat ageism in healthcare? I'd love to hear your opinions, and thank you, all of you who've been so verbose in the chat room. I appreciate it, and I know that the folks on the call who are not participating also are enjoying your comments, as am I. Ageism is a social justice issue that has implicit interpersonal, environmental, and systemic impacts on our healthcare system. Educate, call it out. Thank y'all. It's imperative that healthcare practitioners are educated, as you said, about strategies to combat ageism. We begin this by cultivating an awareness of our own implicit bias. If you've ever said, I'm having a senior moment, that is one of your implicit ageist biases. We need to improve our interpersonal communication through the doing away of elder speak when working with older adults. We need to make changes in the healthcare environment and reform the policies that guide the healthcare environment, such as the policy during COVID-19 to triage those who were older away from receiving intervention. This targeted approach considers causes and interventions across each of these levels. And reducing, we've seen again through Dr. Levy's studies that reducing age discrimination is plausible because research shows that negative age stereotypes can be made significantly more positive with intervention and education. Ms. Clark says, implement the same ethics we use with all clients, regardless of age. Examples, respect, self-determination. Exactly. Keep bringing awareness to the topic, says Ms. Cooper. Improve our communication, says Ms. Jones. So older adults, as we've said, are a highly heterogeneous group. There are older adults of color. There are disabled older adults. There are older adults of diverse sexualities and gender identities. And there are many, 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 many other identities that we can ascribe to. In fact, we have on YouTube a cultural competency CEU in which we describe the various types of roles and identities that we might be subject to. And there's, nearly 20 of those. And that's just the beginning. There are many identities that each of us hold internally. Ageism, thus, in healthcare is rarely experienced on its own. It intersects with sexism, racism, ableism, transphobia, and other forms of oppression, and leads to the concept of double jeopardy that we discussed at the beginning of the hour, whereas women and men are viewed differently as they age. Ageism and racism, for example, led to COVID-19 disparities in morbidity and mortality, particularly for Black older adults. And someone said in the chat room earlier that ageism can lead to mortality. It, in fact, did for Black adults during COVID. In one study by Stewart, a 63-year-old Black woman was shared the following experience. As I've gotten older, now the question becomes, did that happen because of my age and disabilities and not so much about my race? And sometimes I can't tell the difference. Do you see how pervasive it is? The study found that stereotypes related to mental incompetence may be one way that ageism and racism intersect. Educational initiatives, which you've all said, that we can intentionally counter age and other stereotypes in healthcare to combat the intersections of isms, ageism and sexism, ageism and racism, ageism and transphobia, for example. At the macro level, changing ageist unethical behavior will require changes in policy. And those of you who are in leadership roles, I would put to you to give some thought to this. And we can learn from the mistakes made during COVID-19, such as the use of age cutoffs when determining resource allocation. This was simply habit and was lazy on the part of our healthcare system, no matter the strain it was under. Clinical practice guidelines provided by Montero, Adasso, and others suggested using alternatives to age alone as the criterion for making decisions about resource allocation, because people are living longer and they're living healthier lives. So because of that, we think that the clinical frailty scale may be a more and better multifaceted tool to predict clinical outcomes than simply using age alone. The clinical frailty scale is a score based on the status 2 weeks before the onset of symptoms. So if someone is seeing you in clinic, you think about what they were 2 weeks prior if you're thinking of clinical frailty. And in that scale, a threshold of 5 or greater is where we would want to draw the cutoff for resource allocation. The clinical frailty scale is well validated. It came out of a study of health and aging by Canada. It provides a summary and a tool for clinicians to assess frailty and fitness based on your clinical judgment as the patient presents to you. And it is a multidimensional geriatric frailty is multidimensional and is associated with poor health. It represents decreased physiologic reserve and function that is more prevalent with increasing age, but is not a product of aging itself. It is characterized by increasing vulnerability to physiologic stressors. It is the result of cumulative cellular damage from diverse etiologies over the life course of the individual. And we would say that despite the loss of these reserves, many individuals still function well as they age. We can categorize patients using the frailty scale as robust, pre-frail, or frail, depending on the degree of physiological and functional decline that we see them exhibiting. And it is just that. It is you observing your client and using the scale based on your education and experience and your own self-knowledge. Frailty can develop due to socio-demographic influences like poverty or living alone or low education, to psychological factors like depression, to nutritional issues like malnutrition, to polypharmacy, to diseases and complications like inflammatory states, cancer, endocrine disorders, dementia, and low physical activity. The components of the clinical frailty scale are these. One is very fit. This individual is robust. They are energetic, they are motivated, and they exercise regularly. And that might be how you would best determine if someone is very fit. It's a simple question. How often do you exercise? These people are considered the fittest among their age group. We might consider someone well, someone who exercises on occasion and has no severe disease symptoms. Managing well, which is someone who has medical problems that are well controlled, but they do not exercise regularly beyond routine walking. We might recognize someone as living with very mild frailty, wherein they're not dependent on other people, but their symptoms still limit their activities of daily living. The common complaint might be someone in clinic who says, I'm tired every day. I'm always so tired. And then fifth, this is where we begin to want to have resource allocation. Living with mild frailty is someone who may need help in instrumental activities of daily living, or IADL, such as balancing their checkbook or driving or working outside in the yard or making sure they're taking their medications correctly. This typically might show someone that's impaired in their ability to shop for groceries or walk outside alone or prepare a meal or do housekeeping chores. Living with moderate frailty is the next ding on this scale. This is someone who needs help with all outside activities, such as walking or doing yard work, and with housekeeping. They may also have problems with stairs, may need help bathing, or may even need minimal assistance with dressing. Living with severe frailty, the seventh gauge on this scale, is someone who's completely dependent for cognitive and physical personal care. However, they are not at a high risk of dying. Living with very severe frailty is someone who is completely dependent and could not recover from a minor illness and may be considered to be approaching end of life. And then the ninth etch on this scale is those who are terminally ill, those who have a life expectancy of under 6 months. And for those clients, I think there is no greater service in our nation than hospice under the Medicare benefit. So decisions on access to critical care or mechanical ventilation then should be individualized and not a broad brush stroke, as the state of Alabama did during COVID-19. Older adults' capability and functionality are not tightly tied to chronological age. Frailty helps geriatricians understand and grasp variability seen in older patients, including in the critical care settings. Evidence shows that the frailty status is determined by the clinical frailty scale is useful for identifying older adults who have an increased need for increasing adverse events, morbidity, and mortality in critical care units. And the identification of frailty and its severity can identify those who are more likely to benefit and respond to invasive treatments like the use of a ventilator during COVID. Age alone should not drive decisions for healthcare resource allocation. Instead, we should consider the wishes of the person, and if that person is unable because of their disease or disability or disease state, if that person's unable, we should consult their advance directive. And we've done also sessions on that in our series. The presence and degree of frailty is determined by the clinical frailty scale and other aspects of health before the onset of their acute illness should be considered. And decisions must not must not be based solely on chronological age. Ethical triage requires the identification of clinically relevant facts about individual patients and their likelihood of benefiting from possible medical interventions. Younger patients should not be automatically prioritized over older ones. We rely on medicine to extend our lives, but ageist views may be keeping us from living to our full extent and potential as we age. Our responsibility then as a society is to work on proving how we view aging in ourselves and how we view aging in others as we age. Acknowledging that ageism exists and recognizing that biases permeate society, we must work towards overcoming these unethical ageist beliefs by questioning outdated ideas about aging, like fairy tales, for example, and becoming better informed about the diversities of the aging experience among the older adult population who presents to us. We can reimagine ourselves and our abilities, resulting in better care and better quality of life. Take for yourselves a personalized path in your own later life. And look for long-term solutions to ageism and know that this will require changes in our laws and policies and practice, in our healthcare and housing and business and marketing, in technology, product development, and more. The end of ageism will not happen overnight, but it will take one person at a time to become more aware and then do your part. Keep in mind that the importance of working with people at the individual, group, and collective levels is important in identifying ways to enhance support and combat the effects that you may have internalized about aging and ageism. Encourage a healthy lifestyle and activity in your life and in the lives of your patients and clients to counter the effects of embodied ageism, given the relationship between internalized ageism and health. Keep in mind resources and the type of healthy lifestyle activities that each individual may have access. Cognitive behavioral therapy can also be helpful in working with individual clients because it causes us to interrogate the automatic thoughts and belief patterns we have about aging. These are embedded and self-reinforcing. Cognitive behavior therapy can help us question these. On the group level, provide psychoeducation about ageism and the internalized impacts of ageism on health. And keep in mind that ageism, as someone pointed out in the chat room, affects people of all ages and begins for each of us at a very young age. The good news is that we can intervene at any age. That is our presentation for the day. Our code word is ageism with a capital A, lowercase GEISM. I'm typing again into the chat room the Survey Monkey, excuse me, here I go, Survey Monkey link and the password, which is ageism. Ageism with the capital A, lowercase GEISM. The link is https://www.surveymonkey.com/lowercase r/all uppercase letters with some numbers 3, 2, Z as in zoo, C as in cat, 5, 6, Q. Thank you all for your kind words. I'm glad this was a good topic for you and you felt it to be a good presentation. I hope that this and all of our presentations are worthwhile and beneficial to you. Please join us on Monday of next week, the 13th, when Bill Nolan, who's a frequent guest of ours and an attorney with the Elder Care Law Firm of Alabama, will return with the topic, a continuation of topics with conservatorships and guardianships. So we look forward to that, and we look forward to having you here with us. I'm trying to understand how to end this. It used to have an end button and it no longer does, but that is it for us today. Thank you all so much for being with us. And thank you for all that you do. I hope that these continue to be a good use of your time, and I appreciate you being with us.